Africa. So just as the name suggests, this is an initiative by MDoc Healthcare to build the capacity of healthcare workers, of managers, of clinicians, of hospital administrators across different thematic areas in health. So think non-communicable diseases, areas that need capacity building. Just as you're going on in your practice, there are new best practices that are introduced from time to time. The whole idea of having this is to share knowledge across board. This is a multi-country program. And so we have participants from Nigeria, we have participants from Kenya, and we have participants from Ghana and other countries as well. We have this to share best practices amongst all of us and then also share knowledge. So along the line, we'll have a case presentation that speaks to the topic that we're having, and then our subject matter experts will give us their expert advice on how the case was managed. DJ, next slide. Please note that we'll be recording this session, and so we'll be sharing the video, we'll be sharing PDF version of the slides with everybody after the call. Also, please note that the data that we collected when you were joining the session, you registered. The data that we collect, we are not going to share with anybody. It is purposely for reports, it is purposely for evaluation of our sessions, and it is we use that to inform new initiatives as well. So this is just a snapshot of some of our participants' learning sites. Our participant learning sites are basically the health facilities that join the call with us, and they are the ones that usually grace us with the case presentations that enrich our session. So this is snapshots of our participant learning sites from Nigeria, Ghana, and then Kenya as well. And also, we can't move on without talking about our subject matter experts who have shared their wealth of experience with us along the line. So we have experts from Ghana, we have experts from Kenya, we have experts from Nigeria as well. And we want to extend our gratitude to them wherever they are today. Okay, so who is MDoc Healthcare? Just as I mentioned in the beginning, this program is brought to you by MDoc Healthcare. We are a digital health social enterprise that is focused on optimizing end-to-end self-care support for people living with regular health needs, such as weight management, and then people living with chronic health needs, such as diabetes, such as hypertension, such as cancer. And we do this by harnessing quality improvement methodologies, AI and technology, behavioral science, and then data. We do this via a four-pronged approach. The first one is our Complete Health channel. So just as the name suggests, Complete Health. It is a platform where our members are able to interface with a multidisciplinary team of coaches. So think nutritionists, think weight management experts. Our members are able to interact with them virtually. And then we have an AI chatbot also on the Complete Health channel that is able to help our members answer any health questions that they may have. Another channel we do this is via the navihealth.ai. So think about this. You are looking for a facility that speaks to maybe a health condition that you want to manage. The navihealth.ai can help you do that. Identify facilities, identify healthcare providers close to you that can, provide service to you as well. And then we have our community-based tech-enabled nudge hubs. So think about a physical complete health, where now the member can now meet face-to-face with a coach that they've been talking with on the Complete Health channel. And then we move to the MDoc Quality Network. The MDoc Quality Network is the platform that we are using to deliver this capacity building session today. So we are going to just play a very short video just to show navihealth.ai and how it works. Over to you, DJ.
Hello, in this tutorial, I'll walk you through the sign-up process on NaviHealth. The first step is to enter navihealth.ai into your web browser. Next, click on the sign-up button you can find below. Choose from one of the options to register either as a patient, facility, or healthcare provider. Input your details. You can use a registered phone number or email address of choice. But please note that using a registered phone number is compulsory. Make sure to create a strong password. Once you have done that, click on the Finish button to be redirected to input a 6-digit verification code. Get this code sent to your email or your phone number and click to verify the button to complete the sign-up process to get started on NaviHealth. Once the sign-up process is complete, search for a healthcare service close to your location, and once the result pops up, you can search for a facility close to your location. Once you search for a facility, you can click to leave a review on that facility. Make sure your reviews are 100% authentic and original. Input a display name which is not your profile, and thank you for using NaviHealth.
Yeah, I'm muted. Thank you so much, DJ. Next slide. Great. So this is to let everybody on the call know, if you've been joining our sessions for some time now, we've spoken about our learning management system that we are incorporating into these our trainings. This is a self-directed and self-paced platform that can allow healthcare workers to go on there at your own time, go on there, study at your own pace, just in case you're probably not able to join our sessions live, or you join live, but then you still want to learn more. So the learning management system is there. There'll be a wide range of courses. We'll have CPD accredited courses as well, just to boost productivity and efficient learning as we go. So once the MDoc learning management is ready, everybody will have access to, take a course and boost their productivity. Thank you. So please follow us on social media platforms, on Instagram, on Facebook, on YouTube, on LinkedIn, on Twitter. Follow us at my MDoc so that you are updated with all the training sessions that we'll be having as time goes on. Thank you. Next slide. Great. So please, just some housekeeping rules. Please, you can have your camera on. It just makes it more engaging. The session is recorded. We've mentioned that already. Please raise your hand if you want to speak so that we can allow you to unmute. If you have any challenge, please, Elizabeth is on the call. You can just send her a direct message on Zoom as well so that she can support you where you need that. Great. So this is basically the agenda for today. We've already had the welcome and then the introductions and guidelines. We'll have a pre-quiz. The pre-quiz is not graded. Nobody's grading the pre-quiz to show that maybe you don't know, you don't have knowledge in the subject, or that is absolutely not the case. The pre-quiz is just, we are just using that to measure knowledge gain for the session. So after the session, the same set of questions will be launched and then you answer them. Hopefully at that time, you'll have all the information to answer the questions correctly. And then we'll move in to the topic of the day. We have our subject matter experts here on the call who are going to share their wealth of experience with us on this topic. And then we will have a case presentation. Shout out to Malikem Hospital for agreeing to do this with us today. And then we'll have our expert insights and recommendations on the case. We'll go into a discussion session. We have the post-quiz, a reaction survey, announcements, and then we wrap up. Great. So just as I mentioned, we are going to have a pre-quiz. We are going to launch a set of questions. Please feel free to answer them. So we are launching the questions now. Please, just as I mentioned, we are not grading anybody. So please answer them according to the knowledge that you have on this topic. And then the same set of questions will be launched at the end of the call so that you can answer them based on what you learned from the session. So the quiz is being launched now. Okay, it should be up on your screen. It should be up on your screen now. Please, if you can't see the questions, please let us know so that we can assist you. But if it's not coming up on your screen as we speak, please look at the right bottom corner of your screen. You should see 3 dots or more function over there. Just click on it. You see poll/quizzes. Click on it and then the pre-quiz will be launched. So please go ahead and then start answering the questions. Okay, thank you. I see some responses coming in already. Thank you so, so much. I see some. Please keep the responses coming in. We are not grading anybody. So please put in your answers as much as you think is the right answer. Just put in what you think is the right answer. And then we'll launch the same set of questions again at the end of the call after the lecture so that we can measure the knowledge gained for the session. Thank you so much for those who are already putting in their responses. We are setting aside about 5 minutes for this, so please keep your questions coming in as quickly as possible so we can wrap up and then move on to the main agenda for the day. Thank you. I see so many responses coming in already. Let's keep it coming. We'll be closing the poll soon, so please feel free, answer the questions. Please don't go and look into any book hole. You don't need it. All that information will be shared on the call. So please go ahead. Go ahead. Thank you. Oh, Dr. Surai, I see your comments. Yes. So just as I mentioned in the beginning of the call, this is just to foster peer-to-peer learning. This is looking like it's tailored to Ghana, but like there are a lot of things you actually need to learn as well. So that's fine. Yes, I can see the responses still coming in. Please keep them coming. Also, if you have any colleagues that are interested in joining the call, please share the link that was sent to you to register with them, not the email that you received after registering. So before you even knew about this session, a link was sent to you to register. That is the link you should share with your people if they want to join the session. So we are yet to start. So please share with as many people as possible because these subject matter experts are really seasoned and you want to hear from them. So please share with your colleagues as well so that we can join. We'll be closing the polls soon. We should be closing it in less than 2 minutes. So if you've not put in your responses yet, please go ahead and do that. Yes, let's keep it coming. Let's keep it coming. Let's keep the answers coming. We are not grading anybody, so please feel free to answer to the best of your knowledge. We are also live on YouTube, so you can also join the session from YouTube as well. You can let your colleagues, your friends who are also interested in this session join from YouTube. Okay, so if you cannot see the quiz on your screen anymore, just use the same procedure I mentioned earlier. Just go to the more function, click on the 3 dots. You should see polls/quizzes, and then click on that and it will pop up. This will only happen if you did not submit your responses. But if you've already submitted the responses, you may not be able to see the polls. We'll be closing the polls in a few minutes so we can start our lecture for today. We can start. Thank you. So the YouTube link is in the chat. Please share with others who may want to join via YouTube. Zoom is also still open if they want to join via Zoom. So we have the Zoom link and then we have the YouTube link as well. Thank you. Yes, I can still see answers coming in. Please feel free, answer to the best of your knowledge. Just as I mentioned, the same set of questions will be launched at the end of the lecture so that you'll be able to take these same questions again. And I'm sure by that time, all the answers that you probably got wrong in the pre-quiz, you have them right in the post-quiz. Okay, so we'll be closing the poll soon. Just going to have a brief countdown. Please, if you are still putting in a response, please do it now because we'll be closing the polls in 10, 9, 8, 7, 6, 5, 4. I see some answers coming in. 3, we'll be closing soon. 2, and 1. We have to close the polls now so that we can continue. But don't worry, the same set of questions will be launched again at the end of the class. Thank you. Okay, so we're moving in to the main event of the day. We're going to introduce our subject matter experts for the day. Please, when we start introducing them, please start clapping in the chat so before they decide to change their minds and say that they're not going to teach us anything today. So please, DJ, let's go. We have on the call today our seasoned expert, Dr. Mary Amwaku Coleman. She's a lecturer, she's a public health physician, she's a clinical epidemiologist, and she's a senior research fellow. So please start putting the claps in the chat already before I even finish introducing her. So Dr. Amwaku Coleman is a public health physician, a clinical epidemiologist with her current work focused on non-communicable diseases and reproductive health. She works as a senior research fellow at the Noguchi Memorial Institute for Medical Research and at the University of Ghana, Legon. She has over 20 years experience in clinical work, public health, and research with practical technical expertise in global health program implementation, working in malaria prevention and treatment, maternal health, and non-communicable diseases. She also works as a clinician on clinical trials at the Clinical Trials Unit of the Department of Epidemiology at the Noguchi Memorial Institute for Medical Research. Over the past 5 years, she has been working on research integrity and ethics as well. Apart from teaching at the University of Ghana Medical School and the Ghana College of Physicians and Surgeons, Dr. Amwaku Coleman is passionate about and involved in other capacity building programs for early career researchers. So thank you so much. Just this profile alone should let you know the weight of the people coming to speak with us today. So let's move on to our next speaker for today. We have Professor Kwame Edubonsafo. He is an associate professor at the Department of Obstetrics and Gynecology, the University of Ghana Medical School, and a consultant obstetrician, gynecologist at Kolebu Teaching Hospital in Ghana with remarkable clinical experience. He is a graduate from the University of Ghana Medical School and Utrecht University and has an MSD, PhD in clinical epidemiology. He has extensive research experience in maternal health, including hypertensive disorders of pregnancy, cesarean section, postpartum hemorrhage, preterm birth, respectful maternity care, and maternal mortality and morbidity. Professor Kwame has served as a consultant for WHO on several maternal and reproductive health projects, including respectful maternity care since 2015. I can see the applause already in the chat. Thank you so much, as seasoned subject matter experts for today. And I'm going to hand over to Professor Bonsafo, who is going to start the presentation. So over to you, Prof. Please give me a minute to, yes, we're allowing you to mute now. Okay, over to you, Prof.
Yeah, thank you. Thank you very much, Dorothy. Thank you for the wonderful introduction and all that. And I'm also happy that we have a lot of people joining to listen in. But did we know that in Ghana here, as much as about 40% of pregnancies or births are actually mistimed or even sometimes unwanted at all? And actually, this has led to large family sizes in Ghana. For instance, I was born into a big family. My mother gave birth to 11. I'm the eighth born. When I grew up, I was told that my mother had actually lost two kids. One, I was told, died in the womb, and the other died early within some few days of birth. And in the family, I also witnessed three of my siblings also passing. One behind me was quite small, had a lot of challenges health-wise, and died later on. And I was told by my mom that she was born preterm and had problems, and it looks like he couldn't recover from it and passed on. My auntie also died during childbirth, during the process. And most of these, as you can see, may have come from some of these things. And you can see that in the family, sometimes you eat together. We had a communal living where we ate together. You have to struggle, sometimes to get food because we are all eating from the same bowl. And this brings us to the point where you talk about bed spacing, because surprisingly, we were like 2 years. We had 2 years interval between each of us. And then comes to the point where we have birth interval either short or long. And if you look at my family, 2 years, if you subtract pregnancy from it, you could see the distance. And so just to say that birth interval can be short when it's less than 24 months, or it can be prolonged when it's more than 5 years. That means that if from one birth to the other, if you have less than 24 months in between, from the time of birth to the time of starting the next pregnancy, that may be considered as short. And both short and long can have or any complications. So then what can we do to prolong this short interval? That comes in family planning. And family planning, as we know, is a conscious effort to regulate the number and spacing of births through a temporary, long-term, or even permanent methods. And all couples or individuals actually have the right to decide freely and responsibly the number and spacing of their children, and also to have access to information, education, and the means of doing that. And how do they do that? There are several methods. Actually, you can have hormonal methods and non-hormonal and even permanent methods. So you can see from here that we have the oral contraceptive pills, which are used by some implants, injectables, patches, vaginal rings. You could even have intrauterine devices. Some may use condom and the permanent methods where you can either do vasectomy or female sterilization. And in some women who have just recently delivered also may use exclusive breastfeeding to kind of provide some form of family planning for them, even to prevent them from getting pregnant within the shortest possible time. Others have used withdrawal methods and fertility awareness methods. And you can see that thinking about bed spacing and all that, it is important to understand what we mean by bed space. What kind of space are we talking about? So the diagram you see here gives you an idea. The P stands for pregnancy, the time of pregnancy. You can see P1, P2, P3, and P4, which represent points where somebody decides to get pregnant. And so let's look at even P3 to P4. So this is the pregnancy period, and the outcome is O. So you can have outcome 1, outcome 2, 3, and then 4. So birth to birth interval, that is from one birth here, which is the outcome, to another birth, which is an outcome. If you subtract this 9 months of pregnancy from it, then you get what we call birth to pregnancy interval. So if you look at my situation, our birth to birth interval was 2 years. So if you subtract 9 months from it, then you get about 1.1 year, 3 months. And that can be quite short compared to what I mentioned earlier, that you need at least some 24 months before you get another pregnancy. And then if you look at the outcome, this is an outcome, another outcome. If you subtract 9 months from it, you also get the same birth to pregnancy interval. And then what about birth to conception interval? When you have birth here, this is the conception. That one too, you can have it like, it's the same as birth to pregnancy because this is the birth and conception. So you have birth to pregnancy interval as well. And then you can have interpregnancy interval. That means that this is from birth to pregnancy interval. So that is from one pregnancy ending here to another pregnancy initiating from somewhere there. So that is birth to pregnancy interval. And the birth interval is the time between the woman's last delivery and the index birth. And so you can see from here that other definitions that I want us to consider as we move on include some of the definitions of outcome. So for instance, you can have neonatal mortality or neonatal death when a baby dies within the first month, the first 28 days of birth. And as I mentioned, one of my siblings that I did not see had that, where she died within some few days. And then after 28 days of birth, if you die until the first 1 year, that is what we call post-neonatal mortality. And then you can have infant mortality, which will now be, that is when you die within the first year of birth. That is considered as infant mortality, especially after the first 28 days there. Then we have child mortality, which is death within the first 5 years of birth, and then under 5 mortality when you die also between the first year. That one includes the first year, but this one will be the whole 5 years, but this one will include between the time of birth and then the 5th year. What about maternal mortality? This is the death of a woman whilst pregnant or even within the first 42 days of termination of the pregnancy, irrespective of the duration, whether it was 1 month or even the site, whether it was intrauterine or outside. And this can come from any cause related to or aggravated by the pregnancy or even its management, and not from any accidental causes or even incidental causes. So if you have an accident and you are pregnant, we don't normally consider that as a maternal death, but you can say that is maternal related death actually. And then you can have maternal near miss. This is the woman who nearly died but survived a complication in pregnancy that occurred during the pregnancy or even during the childbirth or within the 42 days of child delivery or termination of the pregnancy. So these are the people who had complications, but for an intervention they are able to survive. And as you can see, my auntie had a maternal mortality during childbirth, and she was bleeding, and she could not be saved. And in that case, you can see that this is something, if she didn't even want to get pregnant and she got pregnant, then she died of something she didn't really want to. So then I realized that we need to look at what pertains in Ghana. In Ghana here, our maternal mortality ratio is quite high, even though it's better than some countries in the sub-region. Our ratio, based on the current WHO estimate, is 263 per 100,000 live births. This is always related to live births, so per 100,000 live births. And then what are the causes of death that our women are dying from? The commonest one is still the bleeding, where they bleed following birth or even during pregnancy. And as I said, my auntie suffered this. And there are others who also die from hypertension, infection, and abortion-related complications. And so moving on to the next slide, you understand why some of these things actually happen and the complications that can come out of that. So what are the risks of closely spaced pregnancy? Like in my case, you could have a preterm birth. The one who comes after me, the ninth born, actually was born preterm and never was not able to actually survive because of the problems and complications. And then the mother can have maternal anemia, where the blood level is down. Emotionally, they may be stressed, and they may also have complications during pregnancy, like uterine rupture, where they can bleed, as occurred in my auntie. And then you can also have rupture of membranes, where their membranes or their water breaks, and then they lose the water out of the surrounding the baby. In addition, they may have infection that can come alongside, and some even go ahead to have what we call preeclampsia, which is where pregnant women actually have hypertension in pregnancy, and then that can be associated with proteins in their urine, and the outcomes can be quite severe because it affects the mother and the baby as well. And if you are not careful, you may lose them altogether, in addition to maternal mortality. And studies show that if the pregnancy to birth to pregnancy interval is less than 6 months, then you stand a higher risk of developing a preeclampsia, and therefore you could also have complications. These other complications are, you can see that on the side of the mother of the baby, you can have where they are born with very low birth weight, less than 2.5. And if you give birth, or if the interval is less than 18 months, or even when it's higher than let's say 59, that is 60 months, then the risk is high. Also, you can have fetal death where they can die in utero, and then you can also have perinatal death. And this occurs when the baby dies either before delivery or immediately after delivery. I'm sure we all know about stillbirth. Stillbirth, where the baby died in the womb. It tells you that if, for instance, your birth to pregnancy interval is less than 6, then the chances of having stillbirth is quite high. And then you can have small for gestational age, where your abdomen or your uterus is quite smaller than expected. And some actually will die within the first 1 week of birth, and that's what we call early neonatal death. And if your pregnancy interval is less than 18 months, others may have neonatal and late neonatal death, but more importantly, you can also have people having infant mortality, which is death within 1 year of birth, and then child mortality, which is within 5 years of birth, and then you can have under 5 mortality. So what are the survival probabilities? Study shows that if you compare women who are able to deliver or get interval between 3 and 5 years before they get pregnant, if you compare that to women who get pregnant within 2 years, as happened in my family, then you see that they have a 1.5 chance or times more likely to survive than within the first 7 days. And then also 2.2 times more likely to survive within the first 28 days. And then 2.3 times more likely to survive within the first year. That's the child mortality, infant mortality here. And then 2.4 times more likely to survive like within the first 5 years of age. So these are things that are very real. So if you don't follow this interval, then you stand a very high chance of having these mortalities. So let's look at what happens in Ghana, for instance. We use Ghana, if you look at the pre-test, one doctor mentioned that we are using Ghana, but we use Ghana as a case study, and I think it relates to other countries in the sub-region, including Nigeria and the other countries. And you can see that the desire for another child, 27% of currently married women want to have another child within 2 years, while 30% want to wait at least for 2 years. The desire to limit childbearing, as you know, Africans, we love family. 33% of women do not want to have children, do not want to have another child, including 3% who have had a permanent sterilization. And then you can see that the desire to limit childbearing among married women was slightly lower. It reduced from about 34 to about 33 in 2020. Whilst the men actually did not want to, they rather had a reduction from 24, an increment. They didn't want to have more children compared to women. It means women actually love babies. Then you can see ideal size of the family among all the women. They thought, 4.5 is okay, but among married women, they wanted about 4.5, as I mentioned earlier. And surprisingly, let's look at this, where 61% of live births and current pregnancy are actually planned. And this is the point I made earlier. Nearly 40% of pregnancies were mistimed or were not wanted at all. Meanwhile, remember that once you get pregnant, you stand the risk of going through all this maternal mortality and complications and all that. But if you don't want to get pregnant at all, then you don't need to get pregnant. And therefore, family planning comes in handy to help with that. And you can see here that wanted fertility rate, the total wanted fertility rate was about 3.4 children per a woman. And then what we realized was about 3.9. This tells you that there's a difference of 0.5 where women don't actually, or families do not want to get pregnant, but somehow they get pregnant and they get complications. And that may lead to some of these complications that we have talked about. So you can see that the next slide, which is this, is telling you about women as to the desire to limit the childbearing and relating it to the number of children. You can see that the higher the number of children, the lower the desire to actually get more children. And that happens also in the same manner in the married women. Let's go to the next slide and we can also look at what is there. This slide is quite interesting, and you can see that this is the total wanted fertility. This is what our women actually want to have 3.4 children per family. However, we are having 3.9. The difference is about 0.5. And this has actually reduced somehow from 1988 to 2022. And you can see that there are still some percentage that who do not want to get pregnant, and they still somehow get pregnant and get complications. And you can see here that this is about the 40% that I talked about, nearly 40%. And then we have about 50% pregnancy that are wanted. Good. Let's move to the next one. And here is also quite interesting. So you can see that this is the contraceptive methods that we went through: injectables, male condom, pills, and all that. And women using any method, you can see that the blue line represents married women, and then the yellow line represents the sexually active unmarried women. And you can see that about 30% of married women are using some form of method, and then 63% using some form of method. But if you look at the modern methods are the methods that are shown to be quite effective. 28% of married women are using any modern method, while 46% are using 46% of unmarried women sexually active are using any method. But when you come to the main methods, as you can see, the injectables are the commonest method that are being used by our women. As you can see from here, male condom, not that much. Implants are also the next one that are being used, as you can see from here. And then you can see traditional methods. Traditional methods are sometimes not very effective. You have to be very mindful about that. And when you look at married women, about any method, that's about 28. And then if you look at all women not married and are sexually active, about 46% of them are using any method. This number is, even though you see to be quite okay, is still low, because these are women who are not married, they are sexually active and do not want to get pregnant now. And so what about the rest? This is an area that we need to be mindful, and also counseling has to come in here. So you can see that our under five mortality is about 40 deaths per 1,000 live births. This is high compared to the WHO requirement. And then you can also see that neonatal death is quite high, 17 per 1,000 live births. And then infant mortality is also very high here. So kindly move on to the next slide. And why are we having this? It turns out that actually we are doing well also with antenatal coverage, where about 88% of our women actually have at least 4 visits, and 98% have some form of visit. And midwives do most of the service delivery, about 80% compared to the others. And surprisingly, you can see that we have about 86% of deliveries occurring in the facilities. What about the rest? As much as 13% of our women deliver at home. And we know that home delivery is quite dangerous. So we need to be, this is an area that we need to also tackle to improve the percentage of women who deliver in health facilities. Cesarean section is quite high, 21%. Let's mention that this occurs, sometimes most of these delivery occur at the periphery, where you may not have highly experienced specialists to do that. And so most of them are referred with complications. And then you can see that postnatal care is also quite good, just that about 13% of people still do not access postnatal care. And that is very important, because then this may affect the neonates. Kindly move to the next slide. Good. And this slide also tells us more about facility delivery. As I mentioned, just a pictorial view of it, where you have about 86% delivering at the health facility, and then 13% delivering at the home environment. And this, you can see how a lot of the deliveries are carried out by the midwives and the nurses, with the doctors and the other members taking less than maybe about 30% here. Kindly move to the next slide. This is about the same. So as you can see, moving on, based on all these problems that we have with women having big and large families, WHO is recommending that after a live birth, then one has to wait for at least 24 months before you embark on the next pregnancy. And this is very important in order to reduce the risk of adverse maternal and perinatal mortalities and complications that we mentioned. Similarly, after a miscarriage or an abortion, it is recommended that women wait until at least 6 months before they embark on a new pregnancy. This is very important to reduce the complications and mortalities that can come with pregnancy and its management. Thank you very much. This is the end of the presentation, and these are some of the references that we use. Thank you for your attention.
Thank you so much, Prof. This has been very insightful. We want to give Dr. Amaku Coleman, you are still on the call.
Yes, I'm here.
Thank you. So Dr. Marco Coleman is also going to share some insights with us briefly. Over to you, Dr. Coleman.
Thank you very much, Dorothy, and good afternoon to everybody on the call. Prof, thank you so much for taking us through those insightful slides. I just wanted to bring our conversation home, since we are health workers gathered around the table discussing all this very important topic. What is our role as health workers in making sure that there is adequate bed spacing within our populations, whether Ghana or Nigeria or Kenya? Just some points of reflection for us. What can we do at our level in terms of our facility to be able to improve bed spacing? We need to find innovative ways of meeting women who are not pregnant, because as per the information that Prof shared, we are meeting the pregnant women, over 98% antenatal care. But how do we meet the women when they are not pregnant, so that we can sell the issue of bed spacing to them and make them adopt them? And what ways are we adopting to even sell the message of bed spacing to them? We know that there are sociocultural factors that impinge on the adoption of family planning. We know that there's health workers, as we speak to the women about the birth spacing, there are times that unfortunately our value systems, our beliefs get in the way in the service provision. And so we either don't think that perhaps, adolescents who have clearly shown us that they are sexually active, they've actually come and delivered and are going home. We don't think we should still prescribe family planning to them, because in our opinion, they are still young and should not be given birth. And these become missed opportunities for us. We think that we have used some methods which did not work for us, or we know people who have used some methods which did not work for them, and so they should not be prescribed to some women, not taking into consideration their personal history and their circumstances. How much information and training are we giving to the young ones who join us in our teams to be able to understand and have the skills for giving family planning, so that they can pass it on to women who pass through our hands? The cost of service. Who is providing commodities for us? How are we engaging stakeholders to be able to make sure that this all-important commodity is available to us? Research has shown that, yes, there are other maternal health methods or interventions that help enormously, but family planning is that single intervention that, if adopted, would really save women a lot from maternal mortality. Because of course, if you don't get pregnant, you don't stand the risk of pregnancy. So as health workers, we should talk amongst ourselves, look at our health facility levels and see how we can incorporate family planning services into the services that we provide in such a way that it is practical and nice to our women. These days, there is social media and all that. How are we leveraging on technology to make family planning accessible to our women, so that they will be able to use these methods? They can go to a corner where they can receive comprehensive services without necessarily interfacing with the parts of the system that sometimes become a blockage to them. These are all things that we should look at. I want to mention again the special groups. So adolescents, displaced groups, women who have had are very much older. How do we make sure that we adopt a patient-centered approach to the care that we give to them, that they can really adopt bed spacing to help us to manage the complications that are related to pregnancy and avoid them and improve our maternal mortality? These are all reflections that I want you to take along. Thank you very much.
Thank you so much, Dr. Marco Coleman. I think that was a very necessary, emphasis on what we have learned today. I think we want to move in straight into the case presentation. DJ, can you please move to the case presentation? And I want to especially give a shout out to Malikem Hospital and Maternity Home, who are supporting this program by sharing their case. We have Kimberly on the call, who will be sharing the case for today. So just as I mentioned, right after the case presentation, we'll have our experts share insights on how the case was managed, just so that we all learn from each other. So Kim, are you here? Let me see, Kimberly. Okay. So Kimberly, over to you. Please unmute and then take us on the ride.
Hi, everyone. Good afternoon. Please, I'm presenting a case on the topic here, and the case was conducted on Madam DB. She's 25 years of age. So we start with her bio data. She's 25 years of age. She's married. She's a Northerner by tribe. She's a Christian, and she works as a fashion designer. Her level of education ended in junior high school, and she has one child. Her last menstrual period was on 24 July 2024. So we move on to her past medical and surgical history. She was diagnosed of severe anemia in pregnancy when she was pregnant, and she has no past surgical history. Madam DB came into our facility on 2nd August 2024. She's gravidan para 1, and she came in for a Jardel insertion. But she presented some complaints, and a history too was taken. So she complained of mild headache, fatigue, insomnia, and dizziness, which started 5 days ago. But the headache is getting better after she started taking paracetamol tablets 1 gram 3 times daily, and on a pain score is about 4. So continuing with her complaints and history, according to Madam DB, she was using one of her family planning method, condom, while she was not pregnant for its dual purposes, which are pregnancy and sexually related infection prevention. After she had her baby, she started using Depo-Provera to prevent pregnancy, which is one of the short-term methods. But she wants to switch to one of the long-term family planning method, Jardel. This is because she most times misses her scheduled dates for the Provera injection. And again, she's not prepared for another baby until her baby turns 3 years. And she's not also getting enough support from her husband and relatives. We move on to her obstetric history. Obstetric history, clients recorded a hemoglobin level of 5.5 gram per deciliter while pregnant and was transfused with 2 units of blood at Volta Regional Hospital Hall on 11th November 2022. Madam DB delivered spontaneously to a live baby boy weighing 2.6 kilograms on 23rd April 2023 at Likwe Bakwe Health Center at 40 weeks gestation. That's her place of ANC visit. But because it's a small place, she was referred to Volta Regional Hospital for the transfusion. The baby cried immediately at birth, recording an ABGA score of 8/10 and 9/10 within the first and 5th minutes, respectively. The 1 year, 3 months old baby is currently doing well. And during the labor process, an episiotomy was done and well sutured with complications because client was well educated on perineal care to prevent any complications or infections, and as well took her medications as prescribed. Continuing with the gynecological history, she experienced her menarche at age 14 and bleeds moderately for 4 days with mild cramps. Currently, she does not menstruate regularly because of the Depo-Provera injection she's using. That's one of the family planning methods. She has no known allergies. There are no known allergies. So we move to her family and social history. Madam DB is married to Mr. FM, and she is a fashion designer, as stated earlier, while her husband is a businessman. She neither smokes nor takes alcohol and does not have any family history of chronic diseases. Some examinations were conducted on Madam DB, both general and systemic examinations, and no abnormalities were recorded or detected. She looked well and was stable when she came in, and she presented the complaints as we stated earlier. She weighs 63 kg and her height is 1.57 meters. Calculating her BMI, we had 25.6 kilogram per meter square. We'll move straight to the management before we come to the diagnosis. Before any management was done or before the client was managed or taken care of, a baseline vital signs were checked and recorded as temperature 37.0 degrees Celsius, blood pressure 169/101 millimeters per mercury, pulse 88 beats per minute, respiration was 21 counts per minute. She was managed on tablet nifedipine 20 milligrams stat, intravenous paracetamol 1 gram, intravenous fluid dextrose 500 ml, and Ringer's lactate 500 ml, of which all these medications were administered as a start dose. After 30 minutes, her blood pressure recorded 148/98 millimeters per mercury, pulse 82, temperature 36.2 degrees Celsius. Continuing with her management, before she was discharged, she was okay, she was stable. So she was counseled on rest, sleep, nutrition, anemia, malaria prevention, to do blood pressure profile for a week, and as well run some laboratory investigations like full blood count, BF for MPs, serum pregnancy test, then come in for a review with the blood pressure profile and laboratory results. She was also encouraged to use a non-hormonal family planning method, such as condom, till a decision is finally made on the Jadel insertion. Status of patients and update. Clients came in a week with all the laboratory investigations, and serum pregnancy test was positive. BF for MPs was negative, there was no MP seen. Full blood count detected no abnormal figures. Blood pressure profile recorded normal range figures, and the last recorded blood pressure was 129/88 millimeters per mercury. So client was fine, except the serum pregnancy test, which was positive, and client was not happy at all. Therefore, client's chosen method, that is Jadel, was not inserted because of the diagnosis we have now, that's pregnancy. She's now pregnant, so we cannot insert any Jadel as a family planning method for her. She was then educated on rest, sleep, nutrition, hygiene, and malaria prevention, to come for a review in a week with pelvic ultrasound scan. In conclusion, client was not able to achieve her desired bed spacing for her children, mainly because she was missing her scheduled dates for the Depo-Provera injections. It is good to have plans for your family, so you can therefore achieve your desired bed spacing for your children by choosing a family planning method such as implants, injectables, condom, pills, among others, and to strictly go for your scheduled visit. I will also encourage we, the service providers, to also follow up with our clients too, and also call them to remind them of their scheduled dates. So we will also help them achieve their best spacing goals. Thank you.
Thank you so much, Kimberly. I think your case presentation was very succinct and very clear for all of us. So I'm going to give the opportunity to Professor Kwame and Dr. Mary to, share their expert insights on the case that was just presented, just to, foster learning amongst all of us. So over to you, our honorable speakers for today. Please, who would like to go first to share their thoughts?
Prof, I think you should go first. Thank you.
All right, thank you. This is a very insightful presentation. I can relate to the presentation because it's one of the common things that can happen to women who actually do not want to get pregnant, but for some reason they get pregnant. And as you can see, even in the earlier presentation, there are a lot of people who do not want to get pregnant, but for some reason they realize that they are pregnant. And I like the concluding aspect where the presenter even mentioned that we should look at, you have to individualize this kind of treatment, because you have to look at which one of the various methods that suits you best. If you are someone who forget to take even your pills every day, then you have to go for maybe the injectable. If you feel like monthly injections too, you might forget the date, then you may have to go for the implant, like the Jadel that the facility actually wanted to provide to the client. And so it's just that I see this as a missed opportunity, because I don't know, I don't know whether it was possible for this woman to have been seen earlier and then quickly give her the choice, the required choice that she wanted. But then now that she's pregnant, I would say that it's not all lost. She can see some reproductive health practitioners, and they may have other options of managing her pregnancy for her. And so this comes to the point where we need to also stress sometimes that some of the complications of some of this medication. Even though you may see that we have some complications from the injectables, from the oral medications and all that, but these are minor complications that you have to look into and maybe treated or maybe advised. Once the person gets the right advice, he may be able to go around some of these complications. But more importantly, we also have to look at the medical eligibility criteria, where for some reasons, some people with some medical complications or conditions may not be, or it may be contraindication for them to take some of those options. And so I like the approach that the facility applied in terms of trying to offer the the Jadel for them. But what I did not get clearly is, even though the patient came, was there a delay? What was the reason why the Jadel was not given to her at the first presentation, and now she had to go and come? I'm not sure whether by the time she came, that's the first presentation, she was already pregnant, and that is something that we don't know.
Okay.
Or
Prof, please. When she came, she was not pregnant, but we did not give it to her because of the hypertension. The BP was high, and it's a contraindication for hypertension for family planning. So we waited for her to do a BP profile before we can go on with the Jadel.
That's great. So in moving on, maybe what we could say is that, could we have offered her another option? We have IUCD or some other option. Maybe she didn't like using the barrier method like condoms and all that. I mean, it's an opportunity. This is just to think around it, to see how best, maybe when we get some of these cases, what are our chances? What are our options? What can we do? So I'll end here and probably ask Dr. Coleman to also add a voice to it, and let's see how we can discuss it. Maybe I'm sure the audience might also want to add one or two comments to it. Thank you very much.
Thank you.
Thank you. I get the feeling that the waiting time between her first visit and her second were not that big. I don't think more than a week, because her first appearance was 2nd of July, 2nd of August when they saw her. So maybe maximum a week. So as Prof says, this must be this is a real case of missed opportunity, a case of a woman who is trying, but things did not work for her. This is a woman who has had a previous bad pregnancy with anemia of 5.5, had to be transfused, and I'll say by the grace of God, made it at 40 weeks with a live baby. And I believe that one of the things you want to emphasize with this woman when she's going home is family planning. I'm not sure if that is how come she came to start the depot, you know, but this is a woman who needs a thorough family planning, counseling, postpartum when she's going home and during the postpartum period when we are seeing her. I don't know. I am hoping that it happened in some way because she started the depot. But obviously, unfortunately, she was not able to stick to it. You know, even when you stick to it, the chance of getting pregnant before is still there, although very small, but she was not sticking to it. And she admits it herself. So I see this woman as somebody who is really interested in the timing of her pregnancy, but unfortunately, her efforts have failed her. She comes to the hospital hoping to get a proper method better than the one she knows is not working for her, and she comes already pregnant. The lessons we have all learned, as Prof has said, and we just need to, as I say, we need to be able to see the women when they are not pregnant, find innovative ways of reaching them in between pregnancies, before pregnancy, some follow-up methods, some corners or links that they can tap into and be able to access us as health workers so that we can give them the help, you know, so that somebody, this is one, and she has a 1 year, 3 months old baby. Somebody should be able to tell this woman 6 months into postpartum that, I mean, this irregular scheduling with your depot is not going to help you. So switch to something so that she doesn't wait till over 1 year and gets pregnant. These are all lessons for us too, but we really need to up our game because there are a lot of women who want help. They don't know where to get it from. Others don't know that they need help, and it's still up to us to go to them with the information and the help. Thank you. But I want to thank this facility. I must say that to be able to even pick the hypertension on that first visit and deal with it is also a plus, because if they weren't thorough, they were going to go ahead and give her whatever she came in for, and we know the risk associated with it. So I'm very I want to commend the facility for being able to pick up the hypertension and putting her on a plan that hopefully will help to resolve this. Thank you very much.
Thank you so much. Thank you. Thank you, Kimberly. Thank you so much, Dr. Maku Coleman. The facility is Malikem Hospital and Maternity Home. So thank you so much, Dr. Maku Coleman has, hammered it down further. And I think we can't emphasize it enough that, we really need to help our women. We really need to reach them before they even reach us. Because just as Dr. Maku Coleman mentioned, most of them need help and they don't even know where to go to. I think we can just go straight into the questions. I think there were a number of questions that came up in the chat. I'm going to read the questions, and then Prof and Dr. Makokoman, you can just help us with some responses on that end. So there was a question that came in, was asking that, thank you, Prof. What is the recommended period of uterine rest following a CS? What is the recommended period of uterine rest following a CS? I'm guessing CS is cesarean section. Yeah.
Thank you for this question. This is a very important question. Sometimes it's quite difficult, but the WHO thinks that at least 18 months, 24 months is good between that period. If you do it lower, you will stand a risk of uterine rupture and other complications that can come in preterm birth and all that. But more importantly, uterine rupture is what we are afraid of mostly. So ideally, if you can wait till 18 to 24 months, that is the best way. Otherwise, you could have, especially if you want to try the labor, that's what we call trial of labor after cesarean section, which is normally abbreviated as TULAC. And then, that's the main thing. So we expect that ideally, if you can go beyond the 2 years, that's the best way. But 18 to 24 months is quite appropriate for you to wait.
18 to 24 months. Okay. Thank you so much, Prof, for that answer. There was another question. The question is asking, okay, so this is a question that it seems like is not really related to what is happening in Ghana. Somebody said that there is currently a pill that is said to offer 6-month contraception for women discovered in just Nigeria. Have you had any experience with it as well? I'd like to know.
I'm not sure. Maybe Dr. Kuma may have heard from the public health point of view, but I'm not sure. What's the name of the pill? Is it a poly pill? There's a poly pill that was being developed, but I'm not sure if that is it. I think it might be the poly pill.
I'm not aware of this as well, but yes, if there is information, she can put the link in the chat so that people can read about it.
Yes, I think that's a good response. So please feel free to put the link in the chat so that maybe we can know what exactly we're talking about. So Prof, Dr. Marco, there are other questions in the chat as well. You may want to respond to them, but I'll be reading the questions just for the sake of time. There's another question by Triumph Bonudie. Sorry if I got your name wrong. A woman who is on FP and not having her menses, is there any medicine for the woman to use for her menses to come? Reading the question, please, can we get a response to that? Is there any medicine, any medication just to induce the over to
to
you.
induce the bleeding? I'll say
Yes.
that, she doesn't mention what type of family planning and all that. We know that for some of the family planning methods, it will make your menses irregular and all that. I'll say that if you're using any form of family planning methods and you're having some of these issues, just go back to your provider and get the help. It's better than we recommending you go and get A, B, or C. Yes, you could actually be pregnant, and then if you go picking anything, you might induce abortion and all that. So just go back to your primary care provider and let them help you. Thank you.
Thank
And
you,
also
Dr.
to add that sometimes I think our ladies want to see their menses by all means. Sometimes we tell them that some of the minor complications or side effects of the medication include you not having your menses as regular as you used to. And it's not going to affect your fertility or anything. So we don't always have to have our menses if you are experiencing something like that. But it's always better to see your doctor, as Dr. Makun has said. Thank you.
Thank you. There's another question by Dr. Suraya Awal. She's saying that in a woman with IUD who presents with symptoms suggestive of PID, say abnormal vaginal discharge, when or when not to remove it for the purpose of treatment? Could you please provide clarity? I think.
All right, so
yes.
let me take this one. This is a very critical, very important question because sometimes we see women presenting with such features. And if you have somebody and you strongly suspect that this is PID, we recommend that you treat a person as you would have treated any other person with PID. And then you leave the IUCD in. If treatment is not, the patient is not responding to treatment, then that is when you want to consider removing the IUCD and continue with your treatment, but not the first instance.
Okay, thank you. I think Dr. Shiraya has a follow-up question. So she's asking that, please, in your experience, what's the uptick in utilization of postpartum IUD in Ghana?
Good. So postpartum IUD is something very important. I mean, it's one of the main things. And if we're able to counsel the women and they agree, it's something that one study that was done somewhere in Kolebu mentioned about nearly 30% uptake. But then also let's know that because the patient has just delivered, if you delivered yourself, the expulsion rate sometimes is higher than somebody who has not delivered because the cervix is already dilated. And if you are not careful, you expel it out. And so it's good. We still have a lot of studies ongoing, but as I said, one study mentioned 30%, between 27 to 30% uptake. but just that the rate of expulsion can be higher compared to somebody who had it when she was not pregnant with the cervix closed.
Okay. Okay, thank you so much, Prof. So Francisca Agambila, I see your hand up. I'll give you the opportunity to just ask your question briefly. But there was one last question in the chat. It's saying, please, what's the maximum interval for myomectomy before pregnancy?
All right, so let me mention here that myomectomy, we normally say that 6 months is okay, because in myomectomy, you would have made a lot of incisions on the uterus, and you need the wound to heal adequately before you go through that. Otherwise, if it's less than 3 months, sometimes you can have a challenge. Between 3 months to 6 months is like somehow controversial, but 6 months afterwards is quite adequate for you to start. We don't also want you to wait for a long time, maybe 2 years or 3 years, because the fibroid might recur, and doctors, the gynecologists are, let me face it, they are extremely afraid of going in to do the second surgery because of the risk of losing the womb, and a woman will be worrying you with all that. So this is something that we need to be extremely careful after myomectomy.
Okay, thank you so much, Prof, for that response. Francisca Abangbila, please kindly ask your question. Your hand has been up for a while. Please unmute and speak.
Okay. Good afternoon to you all, and thank you so much for the opportunity. First of all, I would like to commend our speakers for a wonderful presentation. Honestly, I'm really enjoying the topic being discussed. The part that caught my attention was about the IUCD and the medical eligibility criteria mentioned by Prof. I think this woman really needed to space up her birth. And I think if she was counseled on IUCD, she would have loved it. And even since IUCD doubles up as a contraceptive and emergency, it would have been good. So these women really need our help. And then as healthcare providers, if we could do our best to help them in any aspect, then we'll do so. Because if we were considering the BP, there were other alternatives, just as Prof said. Thank you so much. Mine was just a contribution.
Thank you so much, Madam Francisca. Very much appreciated.
Yeah,
Prof, do you have a comment?
Yeah, I just want to say that this is a very valid point that she has made. And one thing I need to add, even after she has said this, is that in this particular case that we are discussing, maybe, as Dr. Makukoman said, probably 1 week interval. It means that the pregnancy, if it was so early, you could use IUCD as an emergency contraception. Because let me mention that once you get pregnant, it takes up to about 5 days before the pregnancy gets into your womb, and then before implantation actually starts. So if it's within 1 week, you could actually put in the IUCD as an emergency method. So by the time the pregnancy enters into the womb, the IUCD is there, and it will prevent it from implanting. And that is not considered as an abortion because implantation hasn't occurred. So, I mean, just to add to it, after our friend Francisca has mentioned, it just occurred to me that I need to make that point clear as well. Thank you.
Right. Thank you so much, Prof. I think this session has been very insightful. And because of time, we may not be able to take any live questions. So maybe if you have any other comments or question, please drop it in the chat for us. We need to move quickly. We are already running behind time. So we want to move straight into the post quiz. So now that we've had all the information from the lecture, I believe that we are going to be able to massacre the questions as they come up now. So we are going to put up the questions. Please feel free, go ahead and then answer the post-quiz questions. The same set of questions that were launched at the beginning. So the questions are up. Please start. I want to see the responses coming in. Yes, the responses are coming in already. Okay, if you can't see the post quiz, whether you're using a mobile device or a computer to join the session, please look to the right bottom corner of your screen. You will see 3 dots or more function. Just click on that, the 3 dots. You'll see polls/quizzes. Kindly click on that, and then the post quiz questions will launch, and then you can answer them. If you still do that and you can't find a poll, please let us know, because that is the only way to launch the polls. If you submit the poll, you click on submit, you can't take it again. It's just a one chance to put in the answer. So please don't end it if you are not done. Yes, I see more answers coming in. So if you were not here when the pre-quiz was launched, please don't worry. Still go ahead and take the post-quiz. If you cannot access the questions, whether you're using a mobile device or a computer, look towards the right bottom corner of your screen. You'll see the more function or 3 dots. Please tap on it, and then you will see polls/quizzes. Click on that, and then the questions will launch. Yes, so just as we mentioned at the beginning of the call, the presentation slides, the video, the audio will be sent to everybody that registered to join this session today. So don't worry if you were not here from the beginning and you were not part of the conversation at the early stages, you will still have access to it. And then once we launch our learning management system, you'll have some of this content also there so that you can also, at your own pace and at your own time, you can take the lessons. Thank you. We'll be closing the post quiz soon. So let's keep, if you want to wrap up, please wrap up quickly so that we can close and then move. Thank you all. To those who have responded so far, we'll be closing the poll in less than 2 minutes. So just as we did in the beginning, we'll have a countdown and then we will close the polls. Also, please let us know your experience in the chat. Whatever stage that of the whole session really stood out to you, please feel free to type it in the chat. If you loved the presentation by the subject matter experts, please put it in the chat. If you've been joining these sessions for a while now and you've not put any comments in the chat to tell us about how the session has been going, just to help us improve it for you, I think you owe us something. So please go ahead and put in the chat. Let us know what your experience is. Yes, we'll be launching a reaction survey at the end of the call, but then it's good to have, like, you know, your real-time experience of how the sessions have been going so far. So I'll be monitoring the chats. I'm looking at those who are putting in their responses. Thank you so much. Okay, so I think we should be moving to close the polls so that we can all quickly get back to our duties. I know we are all busy. I'll be having the countdown now. So we are closing in 10, 9, 8, 7, 6, 5, 4, 3, 2. We're closing now. And 1. Thank you so much. We are closing the polls now. Thank you. So for all those that are joining us for the very first time, we usually have these trainings, capacity building trainings for all healthcare workers across different thematic areas. So today we're treating issues on maternal and child health, but then we also have sessions on cardiology, we have sessions on patient-centered care, we have sessions on different thematic areas that you can think of. So please look forward to your emails. We'll be sharing these as well. So we'll just go straight into the answers for the questions. So, Prof, if you can help us, we just want to be sure that we really killed the questions. We're giving the correct answers. So I'm just going to read the question briefly, and then you're just going to help us with the answer. So the first question is saying that according to WHO, what is the recommended interval for attempting the next pregnancy after a live birth?
Yeah, so I think as we can see, 77% got it right, and that's the correct answer.
Nice.
That's
Thank you.
very well.
The second question is saying that what is the current maternal mortality ratio in Ghana according to WHO?
Yeah, this one also, as you can see, 263 is the correct answer, as you saw in the slide. But I think some people were not hadn't joined before, but I think they've done well, most of it. So that's
Yes.
correct.
Yes, thank you, Prof. The third question, what is the recommended minimum interval to the next pregnancy after a miscarriage or induced abortion according to WHO?
Here too, the participant did so well. After abortion or miscarriage, WHO thinks that we should wait until 6 months, and I think they got it right.
Thank you, Prof. Question 4, what percentage of women in Ghana are currently using any contraceptive method?
Here you can look at this, the presentation, I think it's, if you look at people who are not married, unmarried women, then you think about 46, and then those who are married, then you are thinking about around 36. And so you can see, I would say that the two answers are quite close. We should accept it that way, because those who are not married, 46, are sexually active, and then those who are married, but as we know, most people who are married, the level was down. We saw 26, 28 plus 9, and it's around 36. So, but the main answer we wanted was around 46 for the unmarried one. That's good.
Thank you, Prof. So question 5, which contraceptive method is most commonly used by women in Ghana?
So this is also, as we saw from the presentation from our friend Francisca, the woman was on injectable, just that she has some challenges. And that's the most common one that people do. Just these days, we are moving on. People may want to move on to other things like the implant, but injectables are the commonest one.
Thank you, Prof. So question 6, prolonged birth to pregnancy intervals have been associated with an increased risk of adverse perinatal outcomes, true or false?
Good. I'm surprised this question really caused a lot of challenge. But in fact, even if you look at the first statement on the slide, both prolonged and short interpregnancy or birth to pregnancy interval are associated with birth outcome. When you have not delivered for more than 5 years and you want to deliver again, the risk is quite high for most of this, including preeclampsia and all those things. So we expected that the answer is true, which most people got though, but others were struggling a little bit here. But let me say that if you wait for so long, if you give birth now, you wait for after 5, 6 years, 7 years, you want to give birth again, the risk is high. Thank you.
Thank you so much, Prof. So the next question is, closely spaced pregnancies increase the risk of preterm birth, true or false?
This is straightforward. I think most people got 92%. This is the one that we are having the highest percentage. That's great. You have done well. I think we should clap for them when we finish.
Yes, Prof. So question 8, low birth weight is not a perinatal complication associated with closely spaced pregnancies, true or false?
Good. This one, low birth weight is a complication, it's a perinatal complication. So the answer is it's not. So if you say it's not, that means what? I think the question was swerving them. It is a complication, actually, so it's false. So they got it right, 37%.
Right. Thank you
Thank
so
you.
much, Prof. Thank you so much for giving us the correct answers for this. So we are moving towards the close of the session. I want to thank everybody for being here today. The newcomers on the call, the old comers on the call, thank you. Please, if you have not put in the chat what your feedback is for us, please do that now before you drop off. And I must say that our immense gratitude goes to our SMEs, our subject matter experts today on the call, Professor Kwame Edu Bonsafo and Dr. Mary Amwaku Coleman. And of course, a shout out to our facilities that helped us to present a case for today's session, Malikem Hospital and Maternity Home, and also Kimberly for your succinct presentation. So let's go straight into our reaction survey for today. We are launching it now. Please just let us know how the session went. It's just 5 questions. Please let us know and then we can proceed. It's coming up now. Yes. So please let us know if the training met your expectations, how helpful was the material. Let us know, and then we can move on. Adora, are you on the call? Please let us know. Thank you. Thank you so far for all those putting in their feedback. We'll be closing this in 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. We are closing the reaction survey now. Thank you all for joining. We'll be having our next session next month in September. Please look forward to our emails. Please look forward to our emails and prepare yourself for the upcoming session as well. Thank you all. Just as we said, we will share the presentation slides. We'll share the video with everybody on the call. Thank you so much. Thank you all for joining today's call. We'll just play our complete health video briefly before we leave today. Thank you all.
Hello, in this tutorial, I'll walk you through the sign-up process on NaviHealth. The first step is to enter navihealth.ai into your web browser. Next, click on the sign-up button you can find below. Choose from one of the options to register either as a patient, facility, or healthcare provider. Input your details. You can use a registered phone number or email address of choice. But please note that using a registered phone number is compulsory. Make sure to create a strong password. Once you have done that, click on the Finish button to be redirected to input a 6-digit verification code. Get this code sent to your email or your phone number and click to verify the button to complete the sign-up process to get started on NaviHealth. Once the sign-up process is complete, search for a healthcare service close to your location, and once the result pops up, you can search for a facility close to your location. Once you search for a facility, you can click to leave a review on that facility. Make sure your reviews are 100% authentic and original. Input a display name which is not your profile, and thank you for using NaviHealth.
Thank you, DJ. You have been very helpful on today's session. Thank you all for joining. Please do well to follow us on our social media channels, on our Instagram, on our Facebook, on our YouTube, on our LinkedIn, on our Twitter. Be looking out for our upcoming programs as well. Please share with your friends, please share with your colleagues and every healthcare worker that is interested in improving health outcomes in Africa. So until next time, enjoy the rest of your day, and I wish you all the best. Thank you.